will be recorded for people to be able to view it after the webinar is over. My name is Samantha Crane. I am the Policy Director at the Autistic Self-Advocacy Network. And this webinar will cover our work on supported decision-making in healthcare contexts and our model legislation that we developed in connection with quality trust for individuals with disabilities. This model legislation is our response to a growing policy need that we identified for alternate frameworks that will help people with disabilities, including people with significant cognitive and developmental disabilities, to make their own decisions in healthcare contexts while receiving the support that they need in order to make the best decisions they can make. I am an attorney. I worked at the Autism Center for Mental Health Law and at a law firm called Quinn Emanuel or Cart and Sullivan before joining the Autistic Self-Advocacy Network as Director of Public Policy. As I said earlier, the webinar I'll be mostly giving an overview of supported decision-making and of our model legislation. If you have concerns, in particular, if you have difficulty hearing or if you have any questions about what I'm saying, please feel free to send that in the chat function or the questions function in the GoToWebinar software. That should be towards the bottom of your sidebar. You'll see a little expandable menu for polls, questions, and chat. There also, I believe, is a way, if you click under attendees, if you click on a little picture of a hand, then that will show your hand as being raised. Actually, it looks like someone already has their hand raised. If you have your hand raised and you don't actually have a question, feel free to lower it. All right, so we will now begin. I want to start by acknowledging our partners. Special Hope Foundation provided the funding for our research and our efforts in this area. We created this model legislation as part of a larger toolkit for transition to adulthood for people with intellectual and developmental disabilities. And I'd also want to thank Quality Trust for Individuals with Disabilities, a local charity based in DC, Maryland, and Virginia that helps represent people with intellectual and developmental disabilities who would like to take on more autonomy and make decisions about their lives. So I want to start with some background. What is healthcare decision-making? It's not just deciding between different treatment options, but it also includes deciding when to see a doctor, which doctor to see, when to seek a second opinion. I'm sorry, for some reason the picture is covering up the text, but that happens. When to seek a second opinion, whether to seek treatment or follow a doctor's recommendations, and whether to ask for a different treatment strategy. Now, all of these decisions, including decision to not seek treatment or follow particular recommendations, all of these decisions can be the wrong decision for a particular person or can be the right decision for a particular person. For example, I had some neck pain and went to a doctor, and the doctor told me to get, I don't know, let's say 8 weeks of physical therapy for my neck. Now suppose I actually go to physical therapy and by week 6, it's taking a lot of my time, my neck feels better, and I want to just sort of say, thanks very much, I'm done. Maybe that's a very bad decision, maybe that's a very perfectly appropriate decision, but everyone makes these types of decisions. Everyone has to decide, is this particular treatment worth it? Is this particular treatment actually helping? Do I want to try and seek alternative treatment? Decision-making can also include day-to-day decisions like taking routine medications, making routine appointments, making follow-up appointments, attending physical therapy or other regularly scheduled health visits, and maintaining your own medical records. These seem like, they don't necessarily seem like decisions in and of themselves, but they're an implementation of a decision. And every time that you take a medication, you're at least deciding, here's when I want to take it. Maybe if I've forgotten to take a medication until later in the day, I might decide to just skip that day because, it might be a bad idea to take it too late in the day and then take another dose early in the morning. Depending on what the medication is. So there's decision-making in really even everyday decisions about how to take care of your health. One thing that people often sort of push back on when they hear about supported decision-making is the sense that when people need support, then that means that they should somehow not be able to have the final say about their health, right? That if you can't make a decision entirely on your own, then maybe someone should be making these decisions for you. And what we say in response to this is that we all need support. Supported decision making is a spot on a continuum. It's actually something that we all do. No one makes their own medical decisions without support, not even doctors themselves. Doctors are supposed to go to another doctor for advice on important health issues. We get decision-making support from our doctors, our pharmacists, from information that we find online, from close family and friends, and in the case of significant health concerns, we might go to support groups and get support from peers who have the same health concerns. Supported decision-making for people with disabilities is actually a natural extension of the support that we all get when we are making decisions about our own health care. People with disabilities might need different kinds of support or different levels of support. But they're still using support in the same way that we do. Nevertheless, people with intellectual and developmental disabilities can face additional challenges when they're making decisions about their health care. For example, people might have difficulty understanding and remembering health-related advice and information, or they might need cognitive supports like visual explanations or simplified materials. They might have difficulty communicating information to doctors and health professionals, or they might need communication supports like alternative and augmentative communication, written communication, using a picture board or an iPad in order to talk to other people, using ASL, or using a sort of an interpreter who understands their speech well and can sort of understand what the person is saying. People might also need support to learn and carry out health-related tasks. For example, they might need help taking their medications regularly, administering insulin or following other kinds of complicated health routines, testing blood sugar. They might also lack access to accessible health information. A lot of the information you might find online about your health diagnoses. Let's say you've been diagnosed with asthma and you want to know what asthma is. People without disabilities can go to WebMD and find information that is aimed at adults without cognitive disabilities. They might even be able to find information that is aimed at children and therefore is at like an easier reading level, for example, and includes more visual information. But there isn't all that much information online about health concerns that's aimed at people who are adults. So you want age-appropriate materials, but materials that are also cognitively accessible and might include visual information for people who need more cognitively accessible materials. At the same time, we have wide consensus in the medical field, and this is a statement that has been made by the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Physicians, and the American Society of Internal Medicine. They all came together and issued a statement that said that after the age of majority, all youth deserve to be treated as adults and to experience an adult model of care. If you'd like to learn more about the statement, that is available in our healthcare transition policy brief, which is on our website, and the website will be shown on the screen later in our webinar. But you know, this is a remarkable consensus that really all people, including people with intellectual and developmental disabilities, have the right to fully participate as adults and experience an adult model of care in the healthcare field. There's some major challenges to actually making sure that people have access to that adult level of care. Only 40% of youth with special health needs received recommended maternal and child health bureau transition planning services. Compared to other youth with special health care needs, youth with autism spectrum diagnoses were only 2/3 as likely to be encouraged to take responsibility for their own health care when they became adults. Others with developmental or psychiatric disabilities are also unlikely to be encouraged to take on adult roles. Why is that the case? Well, it turns out that a lot of people are not encouraged to take on adult roles in their health care because doctors and other professionals, and even families to some extent, might assume that they can't take on an adult role in healthcare contexts. The person's need for support is interpreted as a lack of ability to make decisions at all. And health professionals assume that once a person with an intellectual or developmental disability reaches adulthood, they're not going to be making decisions for themselves because they'll have a guardian to make decisions for them. And when you're expecting that someone will have a guardian, there's less of a perceived need to prepare this person to take on an adult role and make their own decisions. Because of this lower perceived need, there is an inadequate focus on building skills that the person doesn't already have, especially in preparation for transition to adulthood. People will not be as focused on increasing a person's literacy in terms of health care and understanding their own bodies. There is less of a focus on, explaining to people how to talk to a doctor, when to see a doctor, how to make sure that they get routine appointments, and how to manage their health care. Doctors will often speak directly to support persons instead of including people with intellectual and developmental disabilities in conversations about their own health care. And this is often true even when the person with a disability is right there in the room. The doctor will still be speaking to this person's parent or spouse or friend or other family member who's there in the room with them. This is especially true, as we're going to see later, this is especially true when that support person also has decision-making authority, such as when the support person is that person's guardian, either because they're a minor or because they are under adult guardianship. Doctors may even refuse treatment to people with intellectual and developmental disabilities who don't have a guardian, out of fear that people with intellectual and developmental disabilities can't provide informed consent to their own care. We have actually seen this happen as almost a level of policy in certain hospitals or other healthcare, large healthcare providing institutions. We feel this is an Americans with Disabilities Act violation and really a human rights violation, because it means that there are people who are not getting access to necessary health care simply because they don't have a guardian as an adult. The answer that many people in the disability rights community have raised to these issues, the solution that a lot of people have focused on is supported decision-making. Supported decision-making is a system that supports an individual with a disability to make his or her own choices. It can include help with gathering information, understanding options, and communicating with third parties. And the level of support can vary with the level of need or importance of decision. As I mentioned earlier, though, this is something that is not, it doesn't have to be a formulaic process. It's more of a concept, and it's a concept that all of us use. I use supported decision-making every time that I make a major health care decision. I talk to my family, I talk to my doctor, I look up stuff online, I talk to other people who have the same health concern, and I use all of those sources of support in order to get the information that I need to make a decision. Supports in the specific context of healthcare, supports will help people who specifically have difficulty communicating and understanding health decisions and adhering to medical advice. Some people might need supported decision-making or more support in order to make decisions in healthcare than they need in many other contexts of life. For example, some people might be perfectly good at managing their money without any significant support, but they might need a lot of support in order to make health decisions because they're a little bit complicated. On the other side, some people find it a lot easier to make medical decisions than to make other kinds of decisions. So again, we're taking people as they are and giving them the support that they actually need. In supported healthcare decision-making, the person with a disability, as with all supported decision-making, will keep the ability to make final decisions about their healthcare. No one can override them. And supporters are often trusted individuals who could include family, friends, spouse, or even a direct care worker like a case manager, as long as there's a relationship of trust. Such that the person can help rely on that person for support. Substituted decision-making is the sort of opposite of, or it's often treated as the opposite of supported decision-making. And I'm going to sort of step back for a second and define what is substituted decision-making. It's any situation where a person makes a decision on behalf of another person. And that decision could be based on either, the person's perceived best interests or the person's, the decision maker's best guess about what this person would want, or even just, what what kind of decision we think this person should make. It's based on a perceived need to protect a person with disability from exploitation, manipulation, or bad choices. And to be clear, there are going to be some cases where substituted decision making is unavoidable. If I'm unconscious after a car accident, then no one can necessarily ask me what I would like, whether I would like surgery or not. But it is considered, it's considered acceptable for a doctor to provide emergency care and for my next of kin to make medical decisions as long as they're not in conflict with anything that I've previously expressed. So there's going to be some cases where you have to make a substituted decision, even for a person who doesn't have a disability. But there are a lot of cases where a person with a disability is forced into a substituted decision-making system not because they can't express what their wishes are, but because people sort of don't trust them to know what's best for them. The early civil libertarian critiques of guardianship, which is a sort of a prototypical substituted decision-making regime, it focused on avoiding guardianship when the person is not truly disabled, or limiting guardianship in situations where maybe you only need to give guardianship over certain issues. But supported decision-making is basically saying, look, what if the person is truly disabled? They really do need a lot of help in order to make a healthcare decision. But even though this person needs support, we're still going to preserve their autonomy. We're just going to make sure that they get that support. What are some examples in the healthcare context of what supported decision-making is? A supporter could accompany a person to a doctor's appointment and help facilitate effective communication. And I mentioned this already. It could include translating information, prompting a person, hey, weren't you going to mention your knee pain to the doctor? Why don't you talk about that? That would be prompting. A supporter could even just be there to help the person stay calm and help manage anxiety. The supporter could help the person understand their options and make decisions that serve their priorities and values. They could remind the person to make doctor's appointments, or even serve as an intermediary in order to make doctor's appointments. If, for example, the person with a disability doesn't do well over the phone, the supporter could be the one that picks up the phone and makes the appointment. It could be assistance with monitoring health, deciding when to see a doctor, directly assisting a person with treatment routines like medication or insulin, and keeping health records organized. There's no need in a lot of situations to create a formal relationship for supported decision-making. I certainly get support when I make major health care decisions, but I don't necessarily need that to be in the form of a formal relationship. If I talk to my mother and say, hey Mom, what do you think I should do? Or talk to my father and say, hey Dad, this doctor told me to do this, does that sound right to you? Have you dealt with this health concern? I don't need to sign a form or do anything in order to enshrine that relationship. Even in cases where you might want to bring a supporter into the office, you don't necessarily need a formal decision-making agreement in order to do that. The ADA requires doctors to make reasonable modifications to their policies in order to help people with disabilities get access to health care. And that could include making a modification to a policy against bringing supporters into a doctor's office. Now, the modifications still have to be reasonable. So if you're talking about wanting to bring your supporter into a sterile operating room, then maybe that won't be allowed because only people in, doctor's scrubs with medical training will be allowed in the operating room. Or in other situations, for example, let's say I come in with a black eye and the doctor wants to interview me about suspected abuse. Maybe the doctor will insist that my supporter leave the room because, I'm not going to tell a doctor that my supporter is abusing me while the supporter is still in the room. So those are good reasons to exclude a supporter from the room. But otherwise, as a person with a disability or as a family member of a person with a disability, you have every right to accompany or to have an escort in a doctor's office if that's a necessary disability accommodation. Supported decision-making can, however, be formalized through support documents. And there are already a bunch of existing ways to formalize these relationships. For example, a HIPAA release. HIPAA is the law that prevents doctors from talking about your medical information to people other than yourself. And I can sign a HIPAA release, or you can sign a HIPAA release that allows your doctor to talk to your close relative or spouse or friend or anyone who's supporting you who you'd like to be able to get that information. You can sign a healthcare power of attorney, and that's really less of a supported decision-making arrangement, but sort of just choosing a substituted decision maker. The power of attorney means basically that you can have your supporter make healthcare decisions for you in emergencies and other situations where you can't be expected to make that healthcare decision yourself. But it often gets used in order to make sure that doctors talk to your supporter. So suppose you appoint someone as your power of attorney, then that power of attorney, depending on the language of your document, will be able to get your health information and will be able to talk to your doctor. People also will sign a healthcare advance directive that sort of says your wishes in potential future cases. For example, resuscitation, whether you want people to use specific medications for you in certain kinds of health situations, and what your wishes are in terms of withdrawal of life-sustaining care. Now, I'm going to make a bit of a jump here. I'm sorry, to why do we want supported decision-making instead of guardianship? And the reason is because guardianship not only constitutes a significant limitation on people's right to autonomy, but also it makes for worse health outcomes and can sort of exacerbate access to justice issues. In a guardianship, a person with a disability can't make healthcare decisions without the approval of a guardian. People with disabilities, because of that, often become disconnected from their own care and may fail to gain or may even lose decision-making skills. Doctors also sometimes might not understand the scope of a guardian's authority to make decisions about sterilization or withdrawal of life-sustaining treatment. We actually had a case in Wisconsin recently where the Autistic Self-Advocacy Network submitted an amicus brief challenging the University of Wisconsin Hospital, which had been advising guardians to withdraw life-sustaining care from people with developmental disabilities who were not terminally ill. And to give just an example, we had a woman with developmental disabilities who was in her 70s, and she had a case of pneumonia, which was completely treatable. When she went into the hospital, the doctors, took her guardian aside and said, hey, given this person's quality of life, do you really necessarily want to provide antibiotics that will save her life? Maybe we should just give her comfort care and let her die of pneumonia. And the guardian, for one reason or another, said, "Sure, doctor, I trust you." And it wasn't until the next day when this woman woke up and started asking to eat and wondering why she was in the hospital that the guardian realized that their relative did not want to die and wanted to get better. And fortunately, in that case, the guardian did manage to get the doctor to reinstate antibiotics. But imagine a situation where the guardian did not do that, or the guardian was an institutional guardian who didn't visit the person. Then this woman would have most likely died of pneumonia without anyone asking her what her wishes were. Another issue with guardianship is that challenges to the guardian's decision or resolution of conflicts among family members can require a lengthy court process. So if a person with a disability lacks assistance with this process, the challenge might not be possible at all. So imagine, I'll go back to my example of a woman with pneumonia who's in the hospital, and suppose that the guardian is one child, and there are 3 other children who completely disagree with the decision to take her off of antibiotics. They would then have to bring a challenge in court, and they wouldn't necessarily even, depending on the procedural rules of the state, they might not be able to get a decision on that challenge in time, or they might not be able to bring that challenge if they don't have the money to pay court fees. If the person with disability is the one who's bringing the challenge, then it can be even harder, because as we've established, this is a person who might have significant communication difficulties and cognitive difficulties that might make it even harder for them to figure out how to bring the challenge, where to bring the challenge, how to express their objection to the healthcare decision. And not everyone is able to find competent representation to do this. When courts, guardianship courts, have crowded dockets, which they very frequently do, they might not be able to address challenges properly or promptly. They might not be able to get into as in-depth investigation of an issue as maybe they should. And courts actually often avoid, many people have been trying to reform guardianship by asking that courts award only limited guardianships over specific issues. But courts actually often avoid limited guardianships even when the law says that they're supposed to favor them. And that's because if a court awards a limited guardianship and then the guardian comes back to court asking for additional authority, then the court has to have 2 guardianship hearings instead of 1. And in a situation where court dockets are crowded, that can be a burden on the court, and they often just want to avoid that by preemptively giving the guardian all of the authority that they think they'll ever need. There's often even just an assumption that even a guardian who's only seeking a limited guardianship will eventually want to come back to court to get additional authorities. Another issue with guardianship is that it is isolating. Professor Leslie Salzman at the Cardozo School of Law has argued that guardianship inherently restricts an individual's access to the community because they basically have no ability to make everyday decisions without the participation and consent of this particular person. And as I mentioned, with respect to doctors, guardianship can even result in denial of care because doctors, if they're used to having people have guardians, then they'll often deny care to people who don't have guardians under the assumption that, you know, that you just shouldn't be able to have health care without a guardian to make decisions for you. This violates the mandate of Olmsted versus LC, which is a 1999 Supreme Court decision holding that under the ADA, services need to be provided in the most integrated setting appropriate to individuals' needs. If people are entitled to being integrated into the community and to receive services in the most integrated setting, then forcing them into a guardianship arrangement would be isolating that person in violation of Olmsted. We've had some courts actively take this position, and a good example is Damaris L. This is a New York guardianship case that was before former Judge Kristen Booth Glenn. Glenn is now a law professor. Damaris L. was a woman with an intellectual disability who lived in New York, and she married a man who also had psychosocial disabilities. At first, the family, sought guardianship because they thought, this is a bad arrangement, and we need guardianship in order to make sure that she's able to parent. Damaris L. got pregnant, and the family was concerned about Damaris's ability to parent her and make decisions about her child, so they sought guardianship over her. The court, in order to sort of minimize the potential for disharmony between the family and the woman's husband, awarded co-guardianship to both the mother and the husband. Then, due to financial circumstances, the family, specifically the Damaris and her husband, had to move to Pennsylvania from New York. But because the mother was under guardianship, or Damaris was under guardianship, she couldn't move without court approval. So it sort of shows you how incredibly restrictive guardianship can be. The judge didn't just approve the move, but she actually removed guardianship and found that Damaris had developed a robust support network that included both her husband, her mother, her neighbors, her extended family, and social services workers. She found that Damaris and her husband had far more of a partnership than a relationship that was a relationship between a guardian and his ward, and said that with support, Damaris could parent effectively and make responsible medical decisions. She thought that Damaris's supported decision-making arrangements were a less restrictive alternative than the draconian loss of liberty of full guardianship. And for those who can't see the screen, the draconian loss of liberty is a direct quote. Glenn found that guardianship was actually unconstitutional in situations where there was a less restrictive alternative. If a person could live safely in the community with supports from others, including family, friends, and professionals. As I noted, this unfortunately has not, this kind of attitude has not necessarily been seen universally among guardianship judges, despite past efforts at guardianship reform. Previous efforts at guardianship reform focused on limiting when individuals could be placed under guardianship and limiting the scope of guardianship. But it's still sort of assumed that if you did need significant support to make healthcare decisions, then you could still be subjected to guardianship and no longer be able to make your own decisions. Even when courts are required to consider less restrictive alternatives, judges often grant guardianship, even in contested cases, for a variety of reasons. One is they feel like the person should have a legal relationship to their supporter, who will then feel more accountable. They feel that the person with a disability will be exploited outside the context of guardianship if there's a more informal, supported decision-making arrangement. They believe that the loss of legal capacity is essential to protecting people from their own decisions. And they often will not recognize alternative arrangements like a power of attorney or a healthcare proxy, because once a person is declared disabled, once the court finds that the person has significant difficulty making independent decisions about their health care, then as a legal matter, that will invalidate the power of attorney or other contractual relationship. So, for example, in the Guardianship of EL, which is a New Hampshire case from 2006, a judge rejected a power of attorney as a less alternative option, a less restrictive option, because, quote, a power of attorney would not be sufficient because EL could cancel it, unquote. And in Mary J., a judge in a guardianship case that was based on a person with dementia, a judge rejected a less restrictive alternative such as a healthcare proxy and power of attorney because the woman with dementia lacked legal capacity to sign that. And to be clear, this is a woman who had very strong opinions. She wanted one of her 3 children to make medical decisions for her. And the judge instead awarded guardianship to the other 2 children who she specifically did not want to be making medical decisions for her. And it was not, the judge certainly didn't find it unreasonable that the person would want this, child number 3 to make her medical decision because she lived with that child. So there were reasons to, that this woman would rationally feel that the child that she lived with knew more about her priorities than the 2 children that she did not live with. But it found, it awarded guardianship to the other 2 children instead. The other problem with simply limiting guardianship is that doctors can, as I noted, deny treatment to people who aren't under guardianship. They might fear that if a person is determined to lack capacity to provide informed consent, then they can face liability for providing medical treatment to that person unless they have consent from a legal guardian. And this liability will attach even if a person with a disability doesn't object and the medical procedure is objectively beneficial and appropriate. This can really harm people who have decided, along with their families, that guardianship is not right for them. And it can harm people even who might have sought guardianship but can't afford a court procedure. And access to legal representation is a significant issue in American society. Informal arrangements, or existing formal arrangements, are also not a great policy response to the problem of too much guardianship because, as I said, they can be declared invalid if a person has a significant disability at the time that they sign the document. Courts might not recognize those documents as valid, like in the case of Mary J. And doctors, because of that, will be afraid of honoring documents that were signed by a person with a cognitive disability because they'll worry that that document will later be declared invalid by a court. And finally, another reason why existing healthcare powers of attorney aren't the best answer to helping people make their own decisions is because they really are substituted decision-making documents. If I appoint someone as my healthcare power of attorney, I'm saying that I want this person to make decisions for me in situations when I can't. But it doesn't really cover the situation where I want to keep the ability to make my own decisions but also get support. Supported decision-making agreements are our answer to this issue. We developed model legislation recognizing these agreements, and they're different from any existing structure. Unlike healthcare powers of attorney, they specifically only allow a person to provide support. They do not allow a person to make decisions on your behalf. If you want to get someone to make decisions on your behalf in case of an emergency, you would have to sign a separate healthcare power of attorney. And they are unlike guardianship in that they're completely voluntary, and again, they're not substituted decision-making, they're supported decision-making. We developed the legislation in collaboration with the Quality Trust for Individuals with Disabilities, which is a DC-based nonprofit focusing on self-determination for people with significant disabilities. The benefits of this legislation is that it gives people a clear option to create a recognized support relationship. As I noted, a lot of judges are wary of alternatives to guardianship that aren't formalized, that don't give someone, don't involve someone being named as the responsible person. It also avoids costly, traumatic, or lengthy court proceedings. You can execute this in one day, and it doesn't have to be a production. You don't have to go to court. You don't have to hire an expensive attorney for hours and hours. And it actually protects people from many forms of abuse and exploitation because the person retains the ability to go against the wishes of a support person. The support person cannot have you sterilized against your will. The support person cannot force you to take medication that is bad for you and is making you feel sick. The support person cannot act to deny you medical care or consent to invasive medical procedures that aren't in your interest. You always have the ability to cancel a relationship or simply just not agree with the support person's advice. It allows supported decision-making arrangements in healthcare contexts. We're specifically focusing on healthcare. These arrangements will not allow a supporter to help a person make financial decisions or help a person make other housing decisions, any other kind of decision. That person might informally provide the support, but we really specifically wanted to focus on healthcare because it's a little bit different from other situations. Supporters, for one thing, healthcare is a situation where supporters might need a recognized relationship in order to get health information under HIPAA. But also, healthcare is sort of a special situation because doctors are often specifically wary of treating people with intellectual disabilities out of issues with informed consent, and because the presence of a doctor in all healthcare decisions can provide a certain amount of intrinsic protection against truly abusive decisions. The doctor doesn't have to sign off on care that is medically inadvisable or just wrong. So it's a situation where we didn't have to worry about some other concerns that you might see in financial situations where a person might be engaging in financial exploitation. There's no one, no outside party who has the ability to sort of notice that something's going on. Our model legislation includes a standard form in simple language so that to sort of maximize the ability of people to understand what they're signing. And we provide protection to doctors who follow in good faith directions that are made through supported decision making. This is the URL for our supported decision-making toolkit. You can also just find it by going to autisticadvocacy.org and searching for healthcare transition, and you'll find our article on our healthcare transition toolkit. We had a process for designing this model legislation. We first reviewed published guardianship decisions from the past decade to figure out why courts were awarding guardianship in contested cases. Basically, what is making courts feel that they need guardianship, and can we make something that answers these concerns without requiring people to be under guardianship? And as I noticed, the major factors were perceived lack of acceptable alternatives and the desire to make sure the person is taken care of. We also analyzed supported decision-making legislation in other countries, including Canada, Sweden, and the United Kingdom. Our supported decision-making legislation is actually somewhat similar to British Columbia's representation agreements, which are also private agreements that provide the ability to name a supporter to make decisions. Unlike British Columbia's representation agreements, however, these are purely supported decision-making agreements. In British Columbia, your representative can sometimes override your wishes. In our legislation, that is not the case. Our major goals were to make sure that this legislation was accessible to people who had limited financial and educational resources. We didn't want people to need to litigate. We didn't want people to need to hire a lawyer in order to go to court, and especially because that can be very expensive and court proceedings can take a long time. We wanted it to be available, or in fact we needed it to be available to people with significant cognitive impairments. Otherwise, what is the point of our agreement? The process has to be understandable, and the agreement has to be valid even if the person has support needs. We don't want a situation where a court will simply, as in the case with a power of attorney, a court can simply say, oh, well, this person has a disability, so they couldn't have signed a power of attorney in the first place. We wanted it to be valid even if a person has a significant cognitive disability. We also wanted to preserve a person's decision-making rights. They need to make sure that the person has self-determination. And we wanted to, this was also a matter of avoiding abuse, because if you have a private agreement that involves a potential relinquishment of rights, then you would need, a sort of a heightened level of safeguards in order to make sure that that private agreement is something the person understood, and the person understood that they were giving up some rights. The fewer rights the person is giving up, the fewer concerns we need to have about exactly like how much they understood about what they were giving up. We also wanted to alleviate liability concerns that were contributing to discriminatory denial of care. We wanted to respect diversity in the choice of supporters. Some people want their family to support them, some people want a friend, some people want their case manager. We wanted to avoid conflicts of interest. We wanted to prevent abuse and provide a clear process for reporting abuse that would be effective. And we wanted to prevent fraud. The final legislation that we developed along these lines allows a person with intellectual or developmental disabilities to execute a supported healthcare decision-making agreement naming a supporter. They need to have that agreement notarized and witnessed in order to prevent fraud. The supporter is authorized to assist in decision-making, including communicating with, facilitating communication with doctors, obtaining records, health records, making appointments, accompanying a person to appointments, and helping with daily health routines. The person with a disability makes all final decisions, and the decision made with support, this is very important, the decision made with support can count as informed consent. we wanted to prevent fraud, and this is a particularly important concern since it's a private agreement. We needed a private agreement because that it would eliminate the need for court involvement in most cases, which we need in order to make sure people have access. But to make sure that someone doesn't just sign a person's name to a supported decision-making agreement without their consent, we have a requirement that it be witnessed and notarized. The witnesses are subject to the same conflict of interest restrictions that the supporter is subject to. And this is the similar kind of regime that we see in a lot of other high-stakes agreements, like powers of attorney and wills, that they be witnessed and notarized. That is something that our system has basically said, that's pretty good for preventing fraud. It's not perfect, but nothing is perfect, and it is at least as good as a court proceeding. The person with disability must actively participate in decision making. So it's a little bit difficult for a supporter to act without the person's knowledge. They might be able to gain some information by calling the doctor, but really no decision can be made without this person's participation and knowledge. So that also helps prevent fraud. We wanted to minimize conflict of interests, and we did this by restricting who can serve as a supporter. Treating physicians and people with major financial conflicts of interest, such as staff in an institutional setting, cannot serve as supporters. And we intentionally made these conflict of interest provisions. We crafted them to ensure that we weren't unnecessarily excluding spouses, parents, and friends, and home support workers, because these are the types of people who are going to be closest to the person. We don't want them to be automatically excluded from serving as supporters. We needed to make sure that these were available to people with significant disabilities, and we did that by making sure that the agreement was valid even if a person with an intellectual or developmental disability was considered legally unable to execute a contract or provide informed consent without support. We need to do this because otherwise basically all of the people that we were trying to help would not be able to execute the agreement, and they would be forced into unnecessary guardianship or risk denial of care. The agreement still preserves the individual's right to make final decisions and terminate the agreement, which are unlike powers of attorney. Powers of attorney can allow agents to make unilateral decisions for the individual in emergencies. And this means that people are protected in the case of an unforeseen problem with the supporter. If at some point the person sort of has a falling out with the supporter and says, I don't think that you're taking my best interests into an account, that supporter, as always, can't simply override the person with a disability and make decisions for them. Doctors are still able to exercise their traditional role. So if someone is asking for care that they don't feel is medically beneficial or that they feel is actively harmful, they don't have to provide that care. And they don't have to provide care if they believe that the supporter has not been communicating to the individual, hasn't conveyed important information to the individual, or if they suspect that consent was obtained through abuse or coercion. They can report suspected abuse to Adult Protective Services Agency. Now, these agencies are often actually better than guardianship courts at investigating abuse. They often have like maybe a 30-day turnaround time, whereas guardianship courts can take several weeks in order to hold a hearing on a challenge to guardian's conduct. Substantiated abuse complaints result in removal of the supporter, and in states with mandatory reporting laws, reports are mandatory. The doctor cannot simply say, well, I suspect abuse, but I don't feel like reporting it. They have to report to the Adult Protective Services Agency. as far as I know, no state has a mandatory guardianship challenge law, right? A doctor never has to go to a guardianship court and report that the guardian is acting badly. They always are directing those types of complaints to the Adult Protective Services Agency. That's what they're already doing. So it keeps that role. Our next steps in implementing this legislation is we need people to approach their legislators and explain to their legislators that this is something that needs to be done. Right now, no state has passed legislation that recognizes supported decision-making agreements. We do have some courts, like in New York and Virginia, which have recognized that people with intellectual and developmental disabilities can use supported decision-making to make decisions. But so far they haven't created any formal supported decision-making arrangements like the one that we're talking about here. In the meantime, if your state has not passed a supported decision-making law, people can still have informal arrangements, and they can use the form in our model legislation to think through how they want their supported decision-making arrangement to work, and express their intention to form a relationship. But it's important to note that there's no guarantee that that form will be seen as legally recognized or binding in the absence of legislation such as the one that we've drafted to recognize those relationships. And advocates can ask their state legislators to pass legislation recognizing these arrangements using our model legislation as a starting point. And now I'm going to open up the floor to questions. I know that a lot of people who are planning on being on this webinar have some questions or comments. We still have almost 25 minutes for discussion. So please feel free to submit a question, type it into chat, or raise your hand. And I already see one question, and I am trying to read them. Okay. Someone says, I am contracted with a hospital but work for a public health agency in the community. Can I still be a supporter? The answer is yes, unless you are a treatment provider for that person. So, for example, my father is a doctor. He worked, he's now retired, but until recently he was in private practice in primary care and infectious disease. But he wasn't my doctor, so he could still act as a supporter. We don't want people to be acting as a supporter for their own patients, because then they're both giving medical advice as a doctor and giving support as a supporter. That wouldn't be great. Some people, I'm sorry, some people were not hearing sound, and I feel very bad for not having seen these questions before. I hope that people can hear right now. But if you can't hear, please raise your hand. I am seeing one raised hand. So apparently most people can hear. And the webinar will be posted online with a transcript for those people who couldn't hear. Another person asked, are there challenges to something like a living will being respected or upheld when it belongs to a disabled person? And the answer is yes. A person with a developmental disability who is found to be legally incompetent by a court might not have their living will respected. And that is because the traditional legal system will basically say if you don't have capacity to make a healthcare decision, then you also don't have capacity to execute a living will or a healthcare proxy. That's the issue that we're really trying to address with this legislation. Can we get a copy of the PowerPoint? Yes, you can get a copy of the PowerPoint. We will post it online. I am just scrolling through. What if the backup plan if the support person becomes incapacitated, and how is it implemented in cases of divorce with joint custody? That is a great question. If the support person becomes incapacitated, we have, the form allows you to name a backup supporter. So you can either name a backup supporter in the form, or you can, if you didn't want to at the time that you first signed the form, you can always execute a new supported decision-making agreement naming a new supporter. And in cases of divorce with joint custody, I'm not entirely sure what that means, like if it's in terms of custody over the person with disability, or custody by the person with a disability over someone else. In general, our supported decision-making agreements were designed for adults, so you wouldn't necessarily have a divorce with joint custody. But if you have a supported decision-making agreement where you name your parents as supporters, then they can both still keep serving as supporters even if they get a divorce. And one thing that's very great about that is that if the two supporters disagree, the person with a disability still has the ability to make the final decision. So they can listen to the disagreeing viewpoints of both of their parents, and then they will be the one who makes the final choice. These questions are, my screen is a little bit weird. So I apologize for taking a little bit of time to get between questions. One person said, are people who provide services through the HCBS or Home and Community-Based Services waiver able to be supporters? People who are in ICFs or institutions are not eligible, but what about people who provide services to people who live outside of their homes? The answer is we were very specifically, we wanted to preserve the ability for home and community-based services workers to act as supporters, but we didn't want them to do so if those workers work in, say, a group home or provider-owned facility that the person lives in. So a group home worker, we would not want to act as a supporter, and that's because we find that group home workers already have so much sort of control over a person's daily life that it would be very difficult for that supportive relationship to continue to be consensual and to continue to be based on keeping the person's autonomy. But if you have a home health worker or someone who is providing supports and doesn't work for the same agency that is housing you, then they can act as supporters. We wanted to make sure that people had access to supporters like home and community-based services workers, because not everyone has a close, trusting relationship with a friend or family member who can provide that support. Sometimes a person's best option is the person that is helping them out on a day-to-day basis. So we wanted to be able to allow that. Can the person with a disability revoke the decision-making document or change the supporter? And the answer is absolutely yes. That is necessary in order to make sure that people retain autonomy and the ability to make their own decisions. The step-by-step process for next steps to contact local and state legislators and a script. That is an excellent suggestion, and yes, we do plan on providing some scripts that will that should be coming out in the next few months. I really like that suggestion. Unfortunately, we haven't already made it, but that's a great idea. My 27-year-old daughter has severe cerebral palsy. She is unable to communicate. We have guardianship, but I've written a letter and asked the court to end our guardianship. I do not have a decision yet. Are we able to do supported decision-making if she is unable to communicate or sign the agreement, and what alternatives would we use? We don't want to keep guardianship, and I am able to communicate with her by watching her facial expression. That is a great question, and I'm a little bit worried about answering specific questions about individual people's legal situations because I'm worried about giving inappropriate legal advice, especially since I don't know what state this person who's asking lives in. But I want to acknowledge that our supported decision-making agreements right now, they're written on the assumption that the person can sign or at least express a desire to sign the agreement. So, for example, if a person has cerebral palsy and can't physically sign an agreement but can say, you know, yes, please sign for me, or yes, I want this, then that should be enough. But if your main form of communication is very interpretive, such as reading a person's facial expression, it might be difficult to establish that the person specifically wants to enter into this kind of agreement. We're still looking into alternatives that would address this situation while avoiding guardianship, but it's just we need to investigate what kind of legal arrangement would allow these relationships while still safeguarding to make sure that the person's wishes are actually being followed and respected. And as just a legal matter, I mean, I know that parents, this parent who just asked has clearly intends to follow and respect their daughter's wishes, but whenever we're passing legislation, we need to make sure that that requirement is legally enforceable and not just sort of a normative expectation. I would love to hear people's input on how to enshrine, how to create truly voluntary relationships in those situations. It's something that we simply have not quite figured out yet. Someone says, where can we find out more, and are there resources more accessible for showing to our loved ones who have DD? Are there resources for advocating for a loved one to be allowed supported decision-making when others are pushing conservatorship, especially if the support person also has experienced forced health care and may not be more respected than a loved one with DD? Those are all great questions. Our website, if you go to our transition toolkit on autisticadvocacy.org, we have a questions and answers document that should be more accessible in more simple language. And another site with great resources for advocating supported decision making is the Jenny Hatch Justice Project. If you Google Jenny Hatch Justice Project, it's a website full of resources. It was established by Equality Trust for Individuals with Disabilities, and it is pretty great in terms of helping people advocate for supported decision making. Another great resource is your local protection and advocacy organization. Every state has a protection and advocacy organization that is dedicated toward protecting the rights of people with disabilities. And if you go to those P&As, then they often will be able to provide a more specific, state-specific advice. Are there any more questions? I am looking through and I don't see any new ones. You can feel free to raise your hand if you have a question, especially if you're like in the process of typing one out. I see that Irina Vaskiev-Mrochek has a question. Irina, I have unmuted you. Would you like to ask a question? All right. Irina, if you remember your question later, just raise your hand again. How about Patricia? Oh, Amy Sequenzia asks a question. I am under guardianship and I live with a friend. Our relationship is already one of supported decision making. She is a licensed provider, though, and I receive HCBS waiver. Her license is foster parent. Can she be my support person in decision making? I think so, because you live in, if I remember correctly, Amy, you do not live, this person does not work for a group home that you live in, so her status as a licensed provider would not prevent her from acting as your support person. The only thing that would prevent her from doing is if she were trying to give you medical treatment, such as like if she was acting as your doctor, and also you said it's her house, our home. Yes, so in that case, she would be able to act as a supported decision-making, as decision support person, as long as she's not also giving you medical advice. So for example, if she were your primary care physician and she were the one, prescribing you medications, and also you're the one supporting you in deciding whether or not to take them, that would be a conflict of interest. But under our model legislation, it would not prevent her from acting as your support person if she's simply a licensed provider and helping you with day-to-day tasks. It looks like, Patricia, do you have a question? Your hand was raised. Do you have a question other than the one you typed into the question box? I've just unmuted you.
No, you answered my question. Thank you.
Okay, thank you. I'm just going through to see if anyone's raised their hands, and I don't see any. Sandra McClellan asks, what is the path toward making this model legislation real legislation? That's very similar to the question about scripts. in terms of how do I contact my legislator and how do I get this passed. What we would suggest, and we can come out with more detailed instructions, but what we would suggest is that you look up who your state representative and your state senator is, and you send them an email or give them a call and let them know that you have that you would like them to look up this and look into sponsoring legislation along the lines of our model legislation. We've already had some interest in Texas in passing legislation that's it's different legislative language, but it's similar to what we wrote. The Disability Rights Texas is trying to promote supported decision-making agreements. And if you live in Texas, you can write to your legislator saying that you would support that legislation. And also, contact your local disability advocacy organizations and let them know that you would really appreciate their support in talking to state legislators and trying to make sure that this is introduced and becomes a reality. Does anyone else have a question? We are right up almost at 4:30. So if I don't have any more questions, then I'm going to close out the webinar. Sandra says, thank you for doing such a good job explaining this, and I really appreciate that. This has been my baby for the past several months. So I am really glad to see so many people come up and listen to the webinar and appreciate it. We will be posting the webinar recording online once we have it captioned, and we will send out a notice to the webinar registration list to let you know when it is up and online so that you can review it and share it. Thank you very much, everyone, and I hope you all have a great day.